Thank you. So now we move on to our second speaker, Professor Ian Wong. He would be speaking on the endoscopic management of anastomotic leaks after esophagectomy. Ian, up to you.
Thank you very much for the invitation, Ramesh, and also thank you ISDE and also the Upper GI Society of Malaysia for the platform. So today my topic is endoscopic management of anastomotic leakage after esophagectomy. So Professor Pateri has already mentioned about the definition and also this ECCG group of the definition in complication. What I want to stress is that anastomotic leakage is actually a spectrum. So the definition and types is only categorizing the treatment or the consequence of leakage rather than the severity or the extent of the leakage. A simple leakage can be dealt with simple dressing if this all the GI contents is leaked in the neck, or if there is a huge mediastinal collection, then there will need to have drainage of the collection as well as the sealing of the leakage as mentioned. And if it is coupled with conduit necrosis, then there ought to be something more invasive, including surgical exploration and resection of the ischemic part in order to help the recovery. And we also have to consider the consequences of leakage, which would include stricture and also potential fistula to the airway, as shown in the picture below. So the simple description of anastomotic leakage would include the whole spectrum of the disease that can be managed conservatively to a very devastating consequences that eventually may cause the patient's life. So we have been discussing about the aim of therapy just now in the question and answer part. So I think the aim of therapy, as mentioned by Professor Pateri, is to have the diagnosis early, which would include the high suspicion and clinical parameters. And also, we should re-establish digestive tract continuity by sealing off the leakage, prevent or treat the ongoing infections, and prevent further contamination by sealing the hole. If there is already got a huge mediastinal collection, then we need to drain it to prevent fistulation and chronic abscesses. And at the same time, we have to provide nutritional support to help the patient in wound healing and in the catabolic phase. So let's first look at the early diagnosis. As you can see in the few images or pictures on the right, it's obvious that if there is neck wound leakage, then there is a obvious anastomotic leakage as well. And from the barium swallow, we can also see there is a sign of leakage here. And obviously from a CT scan, there is a huge mediastinal collection. So these are very useful investigations that would help us in diagnosis. However, we have to stress again on the clinical suspicion to prompt us to perform these kind of investigations, as I think that not all patients would need routine investigations. So how does endoscopy help us? So I'm quoting this study from Sweden just published recently. They are looking at endoscopic videos on day 7. They are looking at it retrospectively with 2 experts, and they use different scoring systems depending on the endoscopic finding to predict the 30-day anastomotic defect, which would include necrosis and leakage. It's commented that the procedure is simple and safe, which I agree. So they looked at 3 different points or location, which includes the anastomosis, the staple line, and the conduit itself, and to grade them in terms of normal healing, as shown as A, B, C, and the signs of ischemia with widening of the slough and staple line, and to frank necrosis. And the conclusion is that if they score 4 or above, there's a high probability of having consequences like leakage or necrosis. On the other hand, if you look at it, 46 of the patients is actually eventually normal, which means they are having unnecessary investigations. And also whether day 7 is the right timing is a point question, because many of the ischemia or necrosis happens before 7 days. And the conclusion from the paper is that the combined endoscopy score was the only predictors of anastomotic complication in multivariate analysis. But what I think is that there should be some hints to prompt us to perform endoscopy instead of a routine endoscopy. Another similar study was performed 2 years ago, where day 7 to day 14, endoscopy was done, the esophagectomy. And the grade this time in terms of degree of degeneration. This is a study from Japan. So as you can see, this is categorized as mild degeneration, and this is categorized as severe degeneration. And severe degeneration is shown to be the only independent variable to predict stricture. So this time the primary outcome is stricture. And the negative predictive value and specificity is quite high. So from our own data, we have also looked at those previous patients from 2012 to 2016. We are not doing routine endoscopy, but we are comfortable in doing early endoscopy within 7 days. So our indication for endoscopy would be initiated by the clinical grounds, including the patient's condition, because it can prompt us to have a prompt diagnosis as well as management in terms of treatment. So as you can see from this table, that an upper endoscopy has a very high sensitivity and specificity together with the clinical information. Whereas compared with CT scan and oral contrast, upper endoscopy gives more information. And for the timing of endoscopy, as the timing of ischemic conduit happens in a median of 3 to 4 days, we have advocated that the endoscopy should be done as long as there is a clinical suspicion. And as you can see, there are other information that can be given by an early endoscopy. So when we go back to the aim of therapy, where we look at the drainage of collection, from anastomosis in the neck to perfilage, the advantage is that the leakage can mostly be drained from the neck wound. And to the contrary, if the anastomosis in the chest, or if the anastomosis, when we have the anastomosis in the neck but push down back to the upper mediastinum, the leakage can cause mediastinal collection. Drainage can be done percutaneously or from radiological guided, but sometimes it can be done endoscopically. This publication has shown some external drainage through the nasal cavity or internal drainage. From the external drainage, it is simply by doing endoscopy reaching a concealed cavity. I have to stress that this has to be a concealed cavity. Otherwise, the leakage can be uncontrolled, and the more intervention within that cavity would cause more harm than good. So within a concealed cavity, we can put an endoscope and put in a catheter for drainage. And for same token, we can put internal stent within this cavity. It's borrowed the method from cystopancreatic and gastric fistulation, where we put in 2 pigtails to maintain the opening and passively draining extraluminal secretion towards the GI tract. The same principle has been done in sleeve gastrectomy drainage as well, and now in other GI tract anastomotic leakage. So this method has been done to compare with endoscopic vacuum therapy, which I will introduce later on. And it shows that the success rate is good they are from different time period. This is from earlier, and nowadays the centers switch to vacuum therapy. The success rate is high. The number of procedure is less than vacuum because they change every 4 weeks, whereas vacuum therapy, you need to change every 3 to 4 days. And you can see that there's a significant shortening of treatment duration for vacuum therapy, mostly due to the frequent reassessment of the cavity and exchange. And there is no significant difference in the primary treatment success, which was defined by no other treatment required. So we're back to how we seal the leakage and to prevent further contaminations. Mechanically, we can close down the defect. However, as Professor Patero has mentioned, tension is one of the key factors as well. So forcefully mechanically close down the defect may not be the best option. However, these are a few options that we can introduce to you. So as you can see, we have different types of clips, which can be categorized as through the scope clips, which are frequently used in POEM procedure to close the mucosal defect, or the over the scope clips, or OTSC. The OTSC has the privilege of closing large defects up to 2 centimeters. It is mounted onto the outside of the endoscope, similar to hemostasis procedure. Endoscopic helix can be done to retrieve more tissue within the cap of the endoscopy, and the whole external cap can be captured onto the defect. As you can see, there's a small defect here, and the tissue is grabbed by the endoscopic helix, and the whole defect is closed by the huge OTSC. It was quoted that the success rate is 60 to 73%, but these include all kinds of GI defects and not limited to esophagus or anastomotic leakage. Another possible tool is endosuturing. Many of you may have heard the Apollo endosuture, which is rather technically demanding, especially when the defect is in the esophagus. The defect is tangential to the instrument, and there's a limited space for manipulation. And I want to show you a short video of this relatively new device called the ISDE, where they use the tech and also suture material to replace the needle and manipulation. And by tightening these taggers, we can close the defect in a figure of 8 or a purse string manner, and eventually tightened by the sieve. So this is relatively new and less technically demanding. So we are eagerly awaiting the results on esophageal leakage. So the so-called gold standard for endoscopic means to close anastomotic defect is stenting. So the ISDE guideline recommends that temporary stent placement can be considered a treatment of leaks, fistulas, and perforations, but there's no specific type of stents to recommend or the duration of stenting to be individualized. So these are the factors that we would consider during stenting. What size do we use? Larger the better? The larger would help optimal adherence of the stent to the esophagus and for better proximal sealing. However, it would exert more pain to the patient, and there's higher risk of erosion and ulceration, and it exerts extra tension to the anastomosis as well. Here is a summary of different brands and size and length and made of stent. So you can see that the diameter can range from 16 to 22. And however, you need to know that the flare is even larger in size to maintain the stent in position, and it would cause a significant impingement of the normal esophagus. And for the length, it ranges from 5 centimeter to normally 15 centimeter. And in some special design of the stent, it can be up to even 23 centimeter, bypassing the whole esophagus and stomach. Migration is one of the complications of stent which is frequently occurred. So these are the anti-migratory mechanisms that proposed. So this stent is called a double stent, where the internal is a cover stent and the external one, the double stent, is uncovered. So it would help anchoring the stent, but in situation where we aim to remove the stent in a short period of time, it would cause significant ingrowth of normal tissue as well. And at the same time, it may impinge on the anastomosis. So other types of partially covered stent would include the central part being covered, where the flare being uncovered. So it could help maintain the position. However, again, it can cause ingrowth of normal tissue. And also, fixation is one of the methods to help prevent migration. As you can see, there is, again, using the endosuture device and holding the tissue and stent in place, or we can use OTSC and other clips for maintaining the position. If the stent is put across the OG junction, there's a problem of reflux. So there are these special designed anti-reflux stents with valve in between, or the PTFE leaflets to act as a one-way valve, so that there won't be reflux of gastric content into the esophagus. However, we found that sometimes these valve and leaflet itself would cause obstruction of the stent itself. So in our sense, it is seldomly used. So about the duration of the placement, it is usually advocated to remove within 4 to 6 weeks and maximum 3 months. And lower adverse events is with shorter interval time. And from the recommendation, it also recommends that the esophageal stent should be removed as early as possible, as long as it's healed. And for the removal technique, once the ingrowth has set in partial cover stent, there are several maneuvers, including debridements by argon beam coagulator, or using this stent-in-stent method, where we insert another stent within the same stent to compress on the ingrowth, causing ischemia and flattening of this ingrowth, and eventually removing both stents. There are other considerations, includes post-operative condition where the esophagus and stomach are not in line and cause angulation. Putting in stent may cause impingement of one side of the flare onto normal esophagus and eventually causing perforation or fistula. And for putting proximal stent, it can also cause impingement for the normal esophagus and cause fistulation. Here's one of the example of stent complication. The patient had three-phase esophagectomy and have a leakage on day 13. And they have failed conservative management, and therefore we put in a stent in the cervical esophagus. And we can see that the stent is way above the clavicle in the cervical esophagus. However, after 32 days, it has migrated to the abdomen, and eventually the patient required laparotomy for removal. So migration, as mentioned, is one of the problems, which can happen in 15 to 50%, and which have more often in benign condition, fully covered stent across OG junction, cervical stent with more swallowing activities, and with concurrent chemoradiation when the tumor, and malignant condition when the tumor is shrunk. And some preventive measure includes partial thickness, anti-migratory fixation, larger diameters, and also the lumen opposing metallic stents, which can be used in cystogastrostomy procedures. So another patient who has undergone 3-phase esophagectomy, this time with mediastinal collection. We have tried to put in a stent by sealing off the leakage, which upon removal, we can still see a large mediastinal cavity with purulent discharge. Therefore, we put in a nasal cavity stent, drainage, as you can see from here. And after drainage of the collection, eventually we put in a stent again, and the patient eventually recovered 95 days. So it's more than 3 months' time. So are there any possibility that we can do prevention of treatment, contamination, and also drainage of the collection at the same time? So here comes the endoscopic vacuum therapy. It was introduced in 2008 with this polyurethane sponge, which is the same as vacuum therapy for wound closure. It can promote healing by having negative pressure, and it can aspirate wound secretion and also stimulate granulation and reduce bacteria and reduce the need of surgical drainage. However, you need to change it every 3 to 4 days. So in the beginning, this procedure is done by endoscopic guidance, where it was delivered by endoscopy straightly into the abscess cavity. And now it is now a commercially available device, and therefore there are different instruments, including the overtube for guidance and insertion. And you can see that the literature on endoscopic vacuum therapy has dramatically increased since 2008. And by applying negative pressure, some may advocate a low negative pressure, but the conventional one is around 100 to 125 millimeter mercury. It can be put within the cavity intercavitary or within the lumen if the defect is smaller than 2 centimeters. Why is it 2 centimeters? Firstly, it's because the size of the sponge is limited, and the larger the size, the more difficult it would be put in. And the anastomotic leakage opening has to emit this overtube, which is size 19 mm, in order to put in this sponge. And again, it's to change every 3 to 4 days. So how is it doing in the terms of results? When comparing metallic stents, statistically, they have no difference, but you can see that there are some potential complications from stents that we have mentioned or will be mentioned. However, you can see that there is significantly lower or shorter duration of treatment time in terms of vacuum therapy, because again, there is more close monitoring and frequent procedure to monitor the healing. There is a recent meta-analysis comparing the closure rate, which favors endoscopic vacuum therapy. And when looking at the number of procedure, of course, it favors metallic stent because it takes longer for one exchange. However, when you look at the duration of treatment, it favors the vacuum therapy. Complication favors, more complication towards stents, and also mortality and duration of hospitalization. So this is another tragedy or nightmare that we have encountered. We have referred from another hospital, which has Lewis tunnel operation and complicated with leakage, as you can see, initially managed by stents. However, after 39 days, terrible things happened when the patient had a stent-induced fistula rather than, or in combination with the anastomotic leakage, because we can see the proximal end of stent protruding into the trachea. Since the anastomotic leakage is still present, we put in another stent which cover both defects. However, this stent is not doing well in terms of proximal sealage, and eventually we have to let the patient to have a wide stent on the tracheal side to cover the airway in order not to have consistent aspiration pneumonia. And later on, we've tried to use a vacuum device, and you can see this quite inflamed scene, which is immediately removing the sponge, which caused some significant abrasion. And you can see the stent on the tracheal side, and defect is still there. And it has been well known that chronic fistula is difficult to manage, whether it's by stent or by sponge. So are there something better to achieve all these aims? So the recent publication on something called stent over sponge have some insights and having all these parameters, because it can achieve lumen patency as well as collection drainage. And the position of the sponge is anchored by the stent. This is a prototype where the sponge is literally outside the stent. And nowadays, this is a commercially available device, which is called a VAC stent, where the proximal and distal stent have a flare in the middle, is incorporating the sponge with a catheter having suction at the same time. And there are some case reports showing initial success, and we are waiting for the long-term results and more prospective data. So in conclusion, we have our own study, on our own review on audit, where we have a leakage rate of around 14%, and 20-something% required surgical exploration. And endoscopic managed majority of them, and in fact, putting in feeding tube itself account for 60% of these endoscopic management, and 30% of them can be managed by stenting. So the conclusion take-home message is that we have to have high index of clinical suspicion in terms of early diagnosis, which prompt us to a safe and procedure by endoscopy, either for diagnosis, assessing the degree of defect, and also doing endoscopic procedure. We have to interpret the evidence available with caution, because all those data that we've presented just now are retrospective, small patient number, and definitely with selection bias. Why would one choose to have vacuum therapy, and why would one choose to have a stent therapy? So there is no absolute indication at all. And eventually, each patient would have individualized management in terms of the location of anastomosis. For example, if we're having in our center free-phase esophagectomy, and more than 80% of the patient, most of the leakage would be in the neck and seldomly needing vacuum therapy. And whether there is presence of ischemia and also associate a collection status of the patient, and whether there's local expertise and also instruments. So thank you again for the opportunity for me to present and share with you my experience, and I welcome any questions.
Thank you, Ian, for this very enlightening outlook on the endoscopic management of anastomotic leaks. Now, just go on to the questions by the participants. The first question is very short. Why endoscopy at 7 days?
Well, in that study, it says that the complication seldom happens before 7 days, and therefore they took that time point. And I think it is a retrospective study. They just use a single time point. As mentioned in our center, there's no absolute time point of whether we should do at whichever days. So it depends on clinical suspicion and signs.
Right, okay. Let me go on to the next question. Interesting option of the over the scope clip. In general, with all closing techniques, how do you drain the mediastinum in those cases to avoid abscesses and fistulas?
Firstly, as mentioned, there are a spectrum of diseases, whether there is a huge collection or not. It can be drained percutaneously or intraluminally. Sometimes in combination, we can have percutaneous drainage, and we then close defects. So the principle is the same, to drain any sizable collection and to prevent further collection by closing the defect. But using OTSC sometimes would cause tension in the defect, especially when the defect is large.
Right. Okay. Again, on the OTSC clips, some with spike and others don't. How do you decide which one to use?
I think the so-called spikes is to capture adequate tissue to incorporate within the clipped area. So usually suction alone would not be adequate in terms of large defects. So it would I would advocate, if you use it to close large defect, then you need to use something like the helix and spikes.
Right. Okay. This is a very interesting question. Do you routinely do gastrographin study prior to feeding? And I'm not sure what's a gentle OGDS for patient post-esophagectomy. So what are your thoughts on this?
Well, our routine is to do neither of them. So if the patient is doing well by clinical, we would follow a standard protocol as in URAS, depending on the intraoperative finding and also the premorbid of the patient. So everything goes well within the operation in terms of like perfusion of the conduit, the suturing and osmosis manner, the tension of the conduit, then we will be happy to let the patient eat without any investigation.
However, so on day what would you allow them to eat actually?
Usually well, for fluids, we are very liberal because we think that saliva is still fluid. So day 2 or 3, we will allow the patient for fluids. However, for really soft or soft diet, then it would be around 5 to 7 days.
Right. Okay. The next question: where do you put the endovac? In the cavity or intraluminally opposite the defect?
Theoretically, it depends on the size of the defect as well as the size of the cavity. And so if the defect is small, it's basically difficult to insert that whole sponge into the cavity because the overtube itself is 90 millimeter. If we don't, we're not using the overtube at all, and when we just put it in, then it would be even more difficult because the sponge is expanded. And so in that case, when the defect is smaller than 2 centimeter, it is advised to put it on the opening.
Sure, yeah. The next question is, what's your view on endoscopic management of cervical leaks? Yeah, which is quite high actually. And what about stents or, what's your view on this?
Well, as mentioned, lucky or not, cervical leaks usually the collection can be drained percutaneously by opening up the neck wound. And by the leakage itself, it all depends on the whether there's necrosis or not. So if there's no necrosis and the defect is small, we usually use stent, provided that there's adequate landing zone.
Length,
Because for example, in our example just now, this cricopharyngeus is a 16, and the anastomosis is a 20. So we still have
some distance.
Some distance. But
so what is your cutoff then? What is your cutoff?
Well, I think
at what point?
Well, 1 to 2 centimeter. I mean, 2 centimeter. Depending on the endoscopic finding and but as mentioned, it is also very easy to have the stent migrated to a frequent swallowing contraction of the upper sphincter.
Back to the sponge. Have you tried longer intervals between changing the sponge?
I think the interval for changing sponge is depending on 2 things. Firstly, whether there will be blockage of the sponge by all the secretion, and as you can see from the second point is, as you can see from the image, there will be a granulation and also inflammation and interaction between the normal tissue with the sponge. So the longer it takes, there will be more damage when you remove it. So the general advice is to remove it 3 to 4 days, and we have tried removing it after 1 week. It is still possible. So there's no
you go up to 1 week then sometimes.
Yes.
Right. Okay. Okay. How long do you normally keep the nasogastric tubes, and do you keep it for intermittent aspiration?
Well, in normal situation without any leakage, we would remove it on day 1 or day 2. But if you are talking about there is significant leakage, it depends on whether the gastric emptying is fine, which can be assessed endoscopically, whether there's residual fluid within the gastric conduit and
Right.
by the amount of NG output. So by means of drainage is not only from the collection, but also any residual fluid that can reflux within the conduit into the collection.
Yeah. Okay. Another question, which do you prefer, gastrografin swallow or the methylene blue if you suspect there's a leak?
Usually we would do gastrographin.
Right.
So we can look at the site and more dynamically with the help of the fluoroscopy and how big, how fast, how distant, how was the tract of the leakage, then it would provide more information. But obviously, sometimes we would ask the patient to have some concentrated grape juice and we can see that it's leaking out from the cervical wound, then obviously we don't need a gastrographin.
Right. What's your recommendation in treating an acute bronchial fistula?
Right. So, well, acute is better than chronic, of course, it's easier.
Right.
So well, there our usual way is to manage as a usual leakage, for example, a stent, and hopefully the fistula can heal by itself. However, for chronic fistula, it's very troublesome and nightmare because we have tried surgical operation separating conduit, and also it will be like a battlefield inside. And eventually, for the example that we've quoted, the patient eventually cannot tolerate any oral diet and required tube feeding to prevent aspiration.
I think this is the last question. What type of anastomosis do you prefer in Ivo-Lewis minimally invasive esophagectomy?
Well, usually, well, in minimally invasive, we usually use a linear slaper. And sometimes we open up a small mini thoracotomy for Henson suture as well. So it depends on the situation.
Right. Okay. Maybe just I would ask one question. Have you had any experience of, despite having stents, there's leakage seeping through the sides of the stent, when the flange, right? Despite the stent actually covering your defect, when the patient drinks, he still leaks. That means it's actually going through the side. So have you come across those kind of situations before?
Yes. Sometimes when, as mentioned, the angulation of the esophagus and stomach would cause impingement of one side of the flare to the normal esophagus, and similarly on the other side it will be away from the esophageal lumen. So sometimes we may use larger stents, however, with a high risk of fistulation ulceration, and sometimes stent may not be a good option in that scenario. Then we may restore back to very traditional way or vacuum. So that's what I meant by individualizing the.
What about a stent in a stent again for those kind of situations?
Well, I don't think it can really bend the angulation. Sometimes we can adjust the distance of the proximal stent. For example, having a longer stent to have a less angulation in the proximal part. But it really depends on the individual whether it works or not. Eventually, it may still not work.
Right. Yeah. Okay. Thank you, Ian, for that excellent presentation on endoscopic management. And thank you, everyone, for your very enlightening questions. Anything more to add, Dr. Batirel and Ian, on today's very exciting topic?
Thank you very much, Ian. Very nice talk, really.
Thank you.
I think I agree with Ramesh that sometimes although the angulation leads to leakage around the stent, sometimes it's related with the size of the esophagus I tried to say it a little bit, but sometimes the tumor obstruction is long time, so the proximal esophagus is dilated. It's like 4 centimeters in diameter, which will not hold any stent. At that point, going up to the neck, especially in an Ivor-Lewis case, is the most important thing, rather than trying to do an anastomosis. And in some of those cases, in a couple of cases, what we had bronchial fistula, we did the same with Ian, that sometimes putting only an esophageal stent and not doing anything to the bronchial fistula may end up healing the bronchial fistula spontaneously if you have a good sealage and if you have a good seal in the esophagus, because the bronchi, and there's not a huge leak to the mediastinum or the pleural cavity, it can seal by itself. We had a few patients in that situation. But I think in that case, if there's some leak around the stent, I would not give anything oral. We just go. I would always give enteral feeding and wait a couple of weeks or more. So eventually, the esophagus kind of most likely shrinks a little bit without any food intake, and the stent is much more snug in the esophagus. I would say.
Yeah, I think there are 2 more questions here before we close. Either one of you could answer this. When stenting an anastomotic leak, we use 2 or 3 overlapping stents to stent from the pylorus all the way up to above the leak. Any experience or comments on this? Ian or Hassan, do you have any experience on this?
Not really.
Well, we
maybe
didn't
Ines, but
try.
I haven't done stent over stent.
We didn't try that before because we usually aim at the anastomosis. But if you're aiming at the pylorus, you can use the mega stent, which is
mega stents. Yeah.
So we don't really need a 2 to 3 stents. And
2 to 3 stents.
And sometimes when it all the way down to the pylorus, it can cause migration as well. So well, since it's a normal and spacious cavity, it will not hold the stent quite well.
Right. Yeah. And one last one. In case of stent placement, what do you prefer? Oral diet, nasoduodenal, or parenteral nutrition?
From the very beginning, after initial stenting, we would usually put in an nasoduodenal tube for the enteral nutrition. And after settling for around a few days, we would do a gastrographin to confirm that the stent has adequately sealed off the leak. And then we may allow the patient for some liquid or milk or supplements diet. And depending on whether there is clinical leak after oral diet, we will continue the management.
Right. Okay. Thank you, Ian. Yes, I think we've done with all the questions. Thank you very much, everyone, especially Ian and Hassan for this excellent lectures. I would just like to remind everyone that the 18th ISDE World Congress takes place in Tokyo, September. Please hand in your abstracts by the 31st of March. Thank you very much, everyone, for joining us today.
Thank you
Goodbye.
very much. Bye.
Thank you very much. Bye.